Welcome to The Explainer. Today, we're diving into a high-stakes clinical scenario that, let's be honest, we all face. A patient on a direct oral anticoagulant, a DOAC, has a breakthrough ischemic stroke. It's that critical moment filled with uncertainty, and the decision we make right then and there can completely change our patient's outcome. So, let's get into the evidence.
Here's the first question that really gets to the heart of it all. Your patient, who is on a modern anticoagulant to prevent this exact thing, has the event you are trying to stop. Your first instinct is probably to change something, right? To escalate the therapy. But what if that very instinct, that switch, could lead to an absolutely catastrophic outcome? And that leads to our second and maybe more fundamental question. When a DOAC fails, is the problem really with the drug's mechanism? Or is that stroke actually a sign, a symptom of a completely different problem that we need to uncover? This is the core issue we're going to unravel today.
So our guide for this is a huge 2025 meta-analysis from the journal Neurology. It's titled Anticoagulation Strategies Following Breakthrough Ischemic Stroke While on Direct Anticoagulants. What's so powerful about it is that it pulls together data from 8 different studies in over 14,000 patients. That gives us the statistical muscle we need for some really clear answers. And of course, the full bibliography is linked for you in the description below.
You know, this scenario is a true clinical dilemma. The major guidelines from cardiology and neurology societies don't really give us a clear roadmap here. For a long time, we've been left to navigate this complex decision with pretty limited evidence. Well, until now.
When we're faced with a breakthrough stroke, we generally think about one of 4 pathways. We could switch back to the old standard warfarin. We might switch to a different DOAC. We could adjust the dose of the current one, or we might think about adding an antiplatelet agent into the mix. Let's see what the evidence actually says about these choices.
We're going to start with the most dramatic finding, and it really centers on warfarin. For years, switching to this vitamin K antagonist might have felt like a solid, robust response, but the data here paints a starkly different and frankly, a very concerning picture.
So this meta-analysis allowed for a direct head-to-head comparison. It pits switching to warfarin against sticking with a DOAC-based strategy, and that includes continuing the same drug, changing the dose, or switching to another DOAC. The results are incredibly clear.
First, let's look at the main goal: preventing another ischemic stroke. The analysis found that switching to warfarin was associated with an 80% higher risk of another stroke compared to continuing a DOAC. An 80% higher risk. That means the very move we thought would offer more protection actually backfires significantly.
Now, let's talk about the most feared complication: safety. The warfarin switch wasn't just less effective, it was far more dangerous. The risk of intracranial hemorrhage, a brain bleed, nearly tripled. A relative risk of 2.90. That is an absolutely powerful, practice-changing finding.
Okay, so the evidence clearly tells us to steer away from warfarin, but what about those other strategies? Does tweaking the DOAC regimen itself, switching brands, changing the dose, actually make a difference?
Well, when the researchers compared the different DOAC-based strategies against each other, so staying on the same drug, switching to a different one, or just changing the dose, they found no significant differences, not in rates of recurrent stroke, not in brain bleeds. This is a huge clue that just tweaking the DOAC regimen probably isn't the answer, because it's not addressing the real underlying cause of the failure. And this brings us to a crucial pivot point. The data is telling us that the key question isn't what drug to use next. The question is why the first therapy failed. A breakthrough stroke isn't just a treatment failure, it's a diagnostic signal. It's telling us to investigate the patient's entire clinical picture.
This analysis gives us a new, memorable framework. Instead of a reactive switch, we need a proactive search. So the new mantra for your practice should be this: don't just switch, go on a search. It's simple, it's powerful, and it's a great way to talk about this evidence-based shift in thinking with your colleagues.
So what are we searching for? Well, this chart breaks it down. The data from these studies points to some very likely culprits. Non-adherence is a massive factor, reported as high as 45% in one study. Inappropriate dosing? That accounts for up to 20% of cases. And then you have competing causes of stroke, things like an underlying cancer or a complex vascular disease that anticoagulation for AFib was never going to prevent. That's about a quarter of all cases.
Okay, so let's translate all of this into a clear clinical action plan, all framed by our new search principle. This is how we take the data and bring it right to the bedside.
Here are the 3 key actionable takeaways. First, avoid the reflexive switch to warfarin. The data is clear. This increases the risk of both another stroke and a brain bleed.
Second, investigate the why. This is the search. You need to systematically check for non-adherence, confirm the dose is right for your patient's kidney function and weight, review for drug interactions, and do a thorough workup for other causes of stroke. And third, favor DOAC continuity. The evidence shows that sticking with a DOAC-based strategy is just plain safer and more effective than going back to warfarin.
To sum it all up, the core message from this powerful meta-analysis is crystal clear. A breakthrough stroke on a DOAC should trigger a diagnostic investigation, not a reflexive prescription change. It's our signal to become a clinical detective and search for that patient-specific root cause. The evidence definitively points us away from warfarin and toward this much more thoughtful, investigative approach.
So the next time you're at this clinical crossroads, this evidence gives you a clear path forward. Think about how you'll apply the search, not switch, principle to change your patient's outcome for the better. Disclaimer and bibliography in the description.